Good morning. It's such a pleasure to be here today and see so many old friends. I'm sorry to say that I won't be able to spend the whole day with you, but it's really a tribute to the enduring importance of this issue that all of you are here today. I've been the health commissioner for 6 weeks. So I'm not, and we have been living with these issues for 2 centuries. Ever since public health data became available in colonial America, it was clear that black people, in particular, are sicker and die younger than the white population. So the title of this day's conference is really apt because we have to think about equity issues that have a past, have a present, and ones that we continue to have an obligation to tackle in the future. And now let me see. So I want to thank the Brooklyn Health Disparities Center. I hope you consider us one of your government partners. And I want to acknowledge also the presence of some of our staff from the Brooklyn District Public Health Office, which is here in New York City. Thank all of you. The center here has been a wonderful asset to our efforts in Brooklyn. I've said that my overarching ambitions as commissioner are to tackle health disparities and to ensure that we put an end to trickle-down public health. And we acknowledge that communities have, that communities have to be involved in identifying the problems they face as well as their solutions. So I'm going to do a framing for you of where we are and give you a sense of how I'm thinking about how we'll go forward. We want to start with an acknowledgement that we have not done enough in city government to either display or commit ourselves to tackling the question of the gap. What we like to talk about, or what we have liked to talk about, is this happy occurrence of ever-rising life expectancy in the United States. It is a tribute to both the efforts of governments, the efforts of communities, the collective actions of communities to improve their own health. And New York City has been doing better than the rest of the country, as you can see. Although in the last couple of years there's been a leveling. This past year we see for the first time that life expectancy in New York City did not go up, and neither did it go up in the nation as a whole. And this should give us pause. But of course, these averages hide enduring and continuing large gaps in the opportunity for a long life by our population. This is New York City, and most of my data are from New York City, and most of our data are from the health department. I hope all of you will acknowledge an important role that the health department plays in making data available to the analysis of these issues. You can see that the Latino population probably reflects the fact that it's largely an immigrant population and therefore has the benefits that immigration bestows. But the black population continues to have substantially lower life expectancies over time than the white population. And the way we talk about these differences is really important. And I just want to highlight that there's important framing issues in using the word differences in populations, disparities in populations, and using the word health equity, which is the one that's framing the conference today. Our language in the health department going forward will acknowledge that these differences are avoidable, preventable, and unfair, unfairly rooted in a combination, this is the definition of disparity, in a combination of adverse working and living conditions, as well as inadequate health care. We have to acknowledge that health care is also a social determinant of health, and a range of social factors, including discrimination. So a key issue, and I know I don't need to say this to any of the people here, is to acknowledge that enduring as these differences are, they are not rooted in biological differences in population groups, that they are social in nature. When we look at a poor community, it means all sorts of things. There are a whole host of social origins: the environment, the housing, the access to jobs, the access to healthy food, that are based on a historical practice of discrimination and exclusion. And New York City, I hope you can see that, is one of the most segregated cities in the United States. If by a measure called the Black-White Dissimilarity Index, which is used by the census, New York ranks number 3, as the most segregated city in the country, and it's been like that for years. That also becomes the basis for place-based approaches, which is what you've been doing in Brooklyn. Because we live in such a segregated city, we can also aggregate our efforts and focus them on communities that are facing the most distress. And that's what we've been doing at the Health Department with the 3 district offices that are located in Brooklyn, the Bronx, and in Manhattan and East and Central Harlem. Because of the patterns of social exclusion, we can also focus our efforts. And I also, a lot of the data that I have to show you today are based on income, not by race. During the previous administration, there was a resistance to presenting race-specific data. I'll be frank about that. And most of the data were presented by income. But in New York City, these are completely overlapping concepts. The neighborhoods that are poor are the neighborhoods that are that are populated by people of color. So I just want to be clear that when I show you data by income, I'm also talking about communities of color. Of course, there is Staten Island has some special issues. It's the epicenter right now of the growing heroin epidemic, for example, high rates of colon cancer. It is not, it's not good to be poor, and no matter what race you are. So these are, so here we are in Brooklyn, where poverty, as it is in the rest of the city, is rife, which continues to be a majority Black and Hispanic borough. We'll see what the next census shows. And of course, the poverty line, the federal poverty line, is a totally inadequate measure of poverty. We all know that. We hardly ever use it on its own. That's why we have these constructions like 138% of poverty, because we know that the poverty line is too low. But the areas where we call them at the Health Department DPHOs are located, I looked at when I returned as commissioner, and they continue to be the areas in the city which have the highest mortality rates, even compared to other communities which are similarly poor. So we know that we're working in the right areas. And although the mortality rates have been declining, as they have for the city as a whole, this gap remains, which reflects an unfair distribution of opportunity for healthy life. This is a slide of premature mortality, and I wanted to show it to you to show what happens when we focus concerted efforts on preventable causes of death. That, if I can figure out how to use my, this is HIV here. So these are deaths before the age of 65. This is HIV here, a condition to which huge effort has been made, including access to affordable housing, income, rental subsidies, special efforts at linking people to care, and of course an effective treatment and prevention program. You can see that we've seen a steady decline in AIDS mortality these conditions, cancer, heart disease, which continue to account for the bulk of deaths among young people, people dying too soon, are also preventable. And I think the experience with HIV should give us a sense of what happens when communities work together. I met with the advocates, HIV advocates, just last week. They're organized, they're demanding their rights. We should all learn from that as an example, and it should be applied to diabetes, heart disease, and so on. Here we are with HIV prevalence. Like most preventable conditions, as they become preventable, we see them concentrating in communities that suffer from disadvantage. And something interesting has happened with HIV. Here you see the mortality rates, and here's the relative mortality. And although mortality has been declining for both poor populations, largely Black and Latino, and wealthier populations, the relative risk has widened. So this reflects, over time, a failure to successfully deliver to the population the interventions that we know work. So we have this almost incongruous observation that relative disparities widen as the mortality declines. Diabetes is a rising problem. It's also high in the communities that we've already highlighted. And here we're seeing some good news in 2010, suggesting that diabetes is declining, but we have not been able to tackle sufficiently the 2.5-fold gap between poor neighborhoods. And chronic liver disease is something that has really changed recently. We have a cure for hepatitis C, which affects nearly 150,000 people in New York City. And similarly, we have enduring gaps. So I've taken all of these together to ask myself and ask our team at the health department, what would happen if we focused our efforts on a narrower set of contributors to the mortality gap? So the height of these bars represents the mortality gap between rich and poor neighborhoods. And what this shows is that about 1/3 to 1/4 of that gap is accounted for by just diabetes, HIV, and chronic liver disease, all conditions about which we know we can make a huge difference. So this is just the way we're starting to frame the question of how we can tackle disparities in a way that is sufficiently focused to mobilize the resources that we need to have the impact that we need to narrow the gap. I think sometimes when we talk about disparities, it's almost like talking about a miasma. People think there's so many things that we have to do, it's so complicated. That's what people have said to me from the press. How can you say you're going to focus on something that's been around for so long, it's so hard, you shouldn't do it? Well, my answer is this is what we have to do. And I know that that's why you're here today. But we also have to do it in ways that hit the ground, that work with communities, and tackle specific diseases and specific risk factors that are taking people's lives too young. So I just want to end with what I began with, that inequities in health are unfair, unnecessary, and avoidable. New York City is the most unequal city in the United States and one of the most segregated. So it's no surprise that we see these realities reflected in the health of the population. But communities have assets as well as challenges and have expertise that they can bring to bear on these problems. That's why it's so critical for community engagement to be a key part of our efforts going forward. This is not public relations. This is how we make things change. And that is why you're all here today and why I'm here to stand with you and say how important it is to address these issues if we're going to improve the health of people in New York. I have to leave at 10 o'clock, and I know that you may have questions. So I'm just going to whiz through my final slides and I highlight these areas as the domains in which the department will be working in the coming years, and speak again to the importance that I place on place-based approaches using the district public health offices as a way to ensure that we're present in communities, working with organizations like the ones here today. And I want to acknowledge the hard work of all the people from the district office who started out with a staff of 7, but are still under-resourced for the task that they face. And acknowledge the collaborations that we have been able to build in the years to come, and which we will continue to build on as I remain commissioner, and redirect more investment to these important areas of work. So I am happy to answer any questions that I have. If there are any, or we can actually get some time back for the program. Yes. Oh, with pleasure.
Anyone else?
And Dr. Ford.
We're truly excited about your vision, and would like to hear you say a little bit more about any preliminary plans in terms of how you envision bridging primary care and public health.
Well, public health has had almost a wall between clinical medicine for years. Part of this is historical. Part of it is that hospitals, and we're in a hospital now, tend to see populations as their patient panel, not as their communities. When, of course, we in public health want the hospital to see a community as its population, not just the people who walk in the door. Now, the whole arena of healthcare delivery is shifting with the Affordable Care Act, with the advent of Medicaid managed care, and the requirement that hospitals begin to look at actual populations as their responsibility. And that represents an opportunity. We in public health, I think, have the skill to bring a population perspective to that. And so I can't tell you precisely how we will do that, but I am seeking actively to build alliances with hospitals. One opportunity coming up soon is the application under the DSRIP program, of which the state is making available, in which large partners of healthcare providers are being asked to tackle specific problems and bring a population perspective to bear on it. So this is an area which remains more a concept than a program of work, but we know that we have data. We know that we have a whole array of programs that we've identified in the Take Care New York agenda that work, and that we should be able to partner with hospitals to prioritize those programs.
Could you make a quick comment on the role of mid-level providers in primary care?
So by that, I assume you're talking about, well, not talking about community health workers, patient navigators, are you talking about that, or are you talking about paraprofessionals like?
Paraprofessionals.
Well, obviously, this is an important extender of physician work. We have supported, for example, in Albany, a law that was on the books saying that nurse practitioners should be able to practice without a supervising attorney. We would like to see the legal envelope for these class of workers relaxed so that they could do their work and not be as constrained by the licensing requirements that currently exist.
Hi, my name is John Hellman with the Latino Commission on AIDS. It's good to see you, Commissioner Bassett. I was wondering if you could share with us some of your plans on how the Department of Health is going to be doing this community engagement. I think it's so important that you're highlighting this necessary part of doing this work. So I was wondering if you could share if you have some planned activities for doing community engagement.
Right. Well, one is on a personal level, as you're aware. I'm determined to get out as commissioner and meet with community groups, and I include in the community professional groups, residents. So one is just how I think the commissioner's office should behave. But from a programmatic perspective, the district offices remain our principal organizational structure in communities. And it really is a philosophical frame that says that we aren't here as the experts just to tell people what to do. I think in the previous administration, and I was part of that administration, and I'm proud of many of the things that were accomplished, there was a tendency to ask two questions. One was, can we save lives? Is there something we can do that will work? And then the next was, do we have the capacity to do it as government? And that was where the conversation ended. And then we went forward to implement. But I think there's a third question that we must also ask, which is, have we given the communities which we are here to serve, the opportunity to comment on our plans and to raise their legitimate concerns and incorporate those concerns into our work. So as commissioner, I can give you my pledge that we do intend to hear those voices. I think we're paying a price now for not doing that with the way in which we lost control of the narrative around the efforts to reduce the portion size of sugar-sweetened beverages. Now, I have, yes, so that's a beginning of an answer, and I'm looking forward to having more programs to tell people about as we begin to implement. Thank you.
What role can academic organizations, from your perspective, play in helping you to achieve this vision? So we're sitting here at SUNY Downstate. We've got a School of Medicine, a School of Nursing, a School of Public Health, health-related professions. That's core to our mission, much more than being a hospital.
Well, I think you have the three elements that are needed to successfully tackle such a complex issue and long-standing issue as inequities in health here today. So we need government, we need academia, its research capacity, and its as well as communities. And all of these capacities exist in all of these realms, right? We in the health department look at data, use data. We are committed to making these data as freely available as possible to our academic partners who may have more resources to analyze these data. I don't want to downplay the importance of advocacy uses of data. And you play an important role in highlighting both need and identifying useful strategies to address that need. So, when I say these things and then I look at how it's quoted in the press, I think, oh gosh, this sounds like, sort of let's stand in a circle and hold hands. And that's not the point. We have to all be held accountable. And our job is not just to all get along. That's not the point. Our job is to improve the health of the communities that we are here to serve. But it does, in fact, need all of us. And if we work together to identify objectives, commit ourselves to obtaining those objectives, and hold ourselves accountable, we will get there. So that's it. Thank you very much.